Now I want to move on to a few other conditions that involve the bile ducts but aren't related to gallstones in any way. And we have two autoimmune conditions, and then we have two types of cancers that we have to go over. So primary biliary cholangitis, previously known as primary biliary cirrhosis, is an autoimmune condition. So let's go over that. So what happens here is that you have some sort of autoimmune reaction. Your body's attacking your own cells, and ultimately you're destroying your intrahepatic bile ducts. So what that'll look like is this region here, through an autoimmune reaction, will start to get damaged and destroyed because of this whole autoimmune process. Classically, you're going to see this, and especially on tests, they always give it as a middle-aged woman with a history of some sort of autoimmune disease. So whether that's Sjogren's, hypothyroidism, type 1 diabetes, RA, celiac, it'll almost always be in a middle-aged woman with some sort of autoimmune history. It's classically associated with Sjogren's, but on tests, any of these are possible. And this middle-aged woman who has this autoimmune condition will usually present with really bad pruritus, intractable itching. It could present with fatigue as well, and biliary obstructive symptoms like jaundice. So the key, I think Boards and Beyond told me this, that always consider, if you ever see a woman with pruritus, the first thing you should consider on test is PBC. And I didn't believe that at first when Boards and Beyond said that, but I don't remember seeing a PBC question where pruritus was not mentioned. So it's actually a really high yield symptom. If you ever see a middle-aged woman with pruritus, first thing you should think about is PBC. And so pruritus is forming because you have so much inflammation in this area that some of the bile leaks out. And remember, a component of bile is bile salts. And if you have too much bile salts in your bloodstream, you can get pruritus. And remember, not only the pruritus, you can also get obstructive symptoms like jaundice, and that's kind of for the same reason. Whenever you have all this bile entering your bloodstream, you can get all your biliary obstructive symptoms. To diagnose this, and this is commonly tested, they love their antibodies, and they love trying to confuse you about the antibodies between this, PSC, and autoimmune hepatitis. So I'm just going to give you some mnemonics to kind of go over each of those. So this is a slide that you'll see later on when we talk about PSC and autoimmune hepatitis as well. We're talking about PBC right now. I always remember PBC from my mnemonic, Itchy Mama. And I remember that. I don't know if you've ever played the game Cooking Mama or whatever it's called, but that kind of reminds me of Itchy Mama. So why I picked this mnemonic to remember PBC? I remember the itchy, obviously, for pruritus. I remember the mama to remind me that this happens in middle-aged women, or moms. And then I also remember mama for the AMA, which is the anti-mitochondrial antibody that's seen in PBC. While we're talking about different autoimmune conditions, I'll just show you how I remember each of these. P-ANCA, I remember P-ANCA as a marker for ulcerative colitis, just like Crohn's has the anti-Saccharomyces cerevisiae antibody, the ASCA. So as long as you remember that ulcerative colitis is P-ANCA positive, when we talk about PSC, we'll learn that it's a complication of UC, so both of them are going to be P-ANCA positive. And lastly, for autoimmune hepatitis, when we talk about this in the liver section, I just want you to recognize that the liver is a smooth organ, and that's why hepatitis is the anti-smooth muscle antibody. Some people this will help out, some people it won't, but it really, trust me, if you learn it now, that's great, but a year from now, it's going to be hard to differentiate if you haven't looked it over. So this is a good mnemonic to kind of help you moving forward. You can also diagnose PBC, with a liver biopsy, and this is going to show you a lymphocytic infiltrate with granulomas. So here's a histologic representation of PBC, and just think of granulomas. I've mentioned this before in a few other lectures that granulomas are basically your garbage cans of your body, and they store trash that can't be excreted elsewhere. And so here you have your lymphocytic infiltrate. All these little purple dots are all your lymphocytes, and you can see all these big granuloma garbage cans kind of existing as well. You can treat this with ursodiol. Remember, that's the medication that we sometimes used to treat gallstones in patients who couldn't have surgery. But ultimately, PBC, it's requires a liver transplant. And there's the mnemonic again, itchy mama. So let's compare and contrast this to another autoimmune condition, primary sclerosing cholangitis, or PSC. So this is a chronic inflammation of not only the intrahepatic bile ducts, but also the extrahepatic bile ducts. So what that'll look like, here's PBC that we've been talking about. PSC also affects the bile ducts that are outside of the liver as well. And again, I want you to think about PSC as a complication of ulcerative colitis, because 90% of people, actually greater than 90% of people with PSC have some underlying inflammatory bowel disease. Most of the time it's UC, it can be Crohn's. On tests, it's always going to be UC. So just remember it as a UC complication, and I think you'll do quite well. This is from our colon lecture. And from our colon lecture, I mentioned that UC always starts at the bottom and progresses up. And I don't know if you remember this, I used the mnemonic of the first letter, the U, and I always remember that because the U ends right here, kind of does this loop right here, it's your inflammation starts at the bottom, whereas Crohn's disease starts with a C. And so that's why the inflammation starts on the left side of the screen here. And that's why the Crohn's usually has problems in this left side of your body right here, this terminal ileum, if you're looking at the body like this. I don't know if that helps, but in UC, it always involves the rectum, and the inflammation always progresses proximally. So you'll have inflammation here first, and then it can spread here over time, and then it gets here. And in PSC, how I remember it, this isn't exactly what's going on, but how I remember it is just that inflammation continues onward and finally reaches the bile ducts, and that's why you get PSC. That's kind of how I think about it in my brain. This will present in middle-aged men normally, and you'll get right upper quadrant pain, fatigue, and jaundice, but you'll also have UC symptoms, and that's kind of how that'll tip you over the edge. They'll either give you somebody who has a history of inflammatory bowel disease, or they'll give you somebody who has these bile duct symptoms, but then they also have these IBD symptoms. So it's you'll see this overlap, and that'll clue you in that it might be talking about PSC. There's a few important laboratory findings you should know about. Because there's obstruction, you'll still get those what are called cholestatic liver function tests. That's just a fancy term for the obstructive pathologies that we've been discussing. You know, elevated C-bili, elevated GGT, elevated ALK phos. So nothing's changed there. And that's happening again because if you have bile here, it all wants to escape out and into your GI tract. But if you have all this blockage in the extrahepatic or intrahepatic ducts, it can flow out into your bloodstream and give you that laboratory picture. Again, it's p-ANCA positive, which is the same as ulcerative colitis, so that's an easy way to remember that. Histology, they like this. I mentioned the histology of PBC is that lymphocytic infiltrate with granulomas, and that's sometimes tested. I think that this onion skin fibrosis is a little bit more high yield. They're more likely to show you a picture, a histology slide of this, and ask you what's going on here. And so this is an onion skin fibrosis. If we have our bile duct here, you can see these onion skins, these concentric layers of fibrosis surrounding the bile ducts. On imaging, they also love this. They love this beating of the bile ducts. So this is a picture of, you can see your gallbladder here and all your bile ducts. And so what's happening here is that these bile ducts, in this case, are doing quite well, and there's no stricture. And in this case here, though, you'll see this classic beads on a string pattern with the bile duct. You can see a bead here, and then it kind of goes normal, and then you see another bead here. And They usually don't show you a picture of this on the test, but they will mention that there's some sort of alternating beading and stricturing. So why is that happening? So in PSC, what's happening is that you get this inflammation of the bile duct, and some of that inflammation will not be repaired, but instead be replaced by fibrotic connective tissue. And some of that connective tissue has contractile abilities and can push in and start to constrict the lumen and form this stricture here. And so if you imagine on cholangiography, you'll see this very small area, and then you'll see a bead, and then you might have a stricture elsewhere, and you'll see a small area, and then you'll see a bead. So the beaded areas are actually your normal areas, even though they look abnormal in that picture sometimes. And so the complications of PSC is that you can have an increased risk of cholangiocarcinoma and gallbladder cancer. So all that chronic inflammation can cause some problems. And again, that's a good segue into our last two conditions, which are the cancers. And these are pretty straightforward. For cholangiocarcinoma, you just have to know that this is a carcinoma of your bile duct cells. And this results from chronic bile duct inflammation. So a risk factor, as we just discussed, is primary sclerosing cholangitis, which in itself is a complication of longstanding UC in most cases. Another thing they sometimes test is that the Chinese liver fluke, Clonorchis sinensis, also increases your risk of cholangiocarcinoma. So that's another thing to keep in mind. And our last section here, our last disease is gallbladder cancer, gallbladder carcinoma. And so this is a cancer arising from the glandular cells within your gallbladder. And again, this is also a consequence of chronic gallbladder inflammation. I feel like we've made a point of saying any sort of chronic inflammation can increase your risk of cancer. We've seen it in chronic insults to your esophagus causing squamous cell carcinoma. We've seen chronic inflammation due to GERD causing like Barrett's esophagus and esophageal adenocarcinoma. Chronic gastritis can cause gastric adenocarcinoma. Chronic pancreatitis can cause pancreatic adenocarcinoma. I guess the only one that we don't really see it with is colon cancer, now that I think about it. That's usually from different genetic mechanisms or from the adenocarcinoma sequence. Anyways, I'm getting off track. Sorry about that. But yeah, chronic gallbladder inflammation causes gallbladder cancer. The risk factors for this is chronic cholecystitis, which we talked about earlier. And here's our picture of chronic cholecystitis with our porcelain gallbladder up here. And just remember that all this chronic inflammation increases your risk of gallbladder cancer. Another risk factor that they sometimes test is Salmonella typhi that can reside in your gallbladder, and so that can also cause gallbladder carcinoma over time. Thanks for watching. I hope you enjoyed the video. Please like, comment, and subscribe for more content.